Good evening to all. And on behalf of IRIA Kerala, I welcome all of you to the IRIA Kerala session PG case presentation on hepatobiliary system in association with Janomed. I welcome Dr. Gomati Subramaniam, President IRIA Kerala, Dr. Rijo Matthew, Secretary IRIA Kerala, Dr. Ramesh Shenai, Program Coordinator. And here actually the sessions are moderated by our President, Dr. Gomati Subramaniam and Dr. Anish. And both are from Malabar Medical College, Calicut. Dr. Gomati Subramaniam, Professor and HOD of Calicut, Malabar Medical College, and she was former professor in Calicut Medical College. And Dr. Anish, Associate Professor in Malabar Medical College. And as you know, both are good teachers in all senses. And Dr. Gomati is very experienced examiner. That's what I can assure you. And all of you know that the Wednesday program now, it is the center point is resident or residents. And today the residents are Dr. Devi Krishna and Dr. Ashwati. Both are from Calicut Medical College. I welcome the moderators and also the residents to this program. And now over to the moderators.
Dr. Anish. Anish, we are not able to hear you.
Yeah, okay. I welcome all once again. I think we can start the session. There will be two cases on hepatobiliary. The first case I will be moderating initially, and the second case Gomati ma'am will be moderating, and we'll be asking questions in between also. Now we can start the session. Case, Dr. Ashwati, you can start the case presentation.
Ashwati, you can share.
Ashwati, give a brief history, patient's age, sex, etc., and then start presentation.
I'm presenting a case of 70-year-old female, Vagdevi, who presented with the complaints of right upper quadrant pain and loss of weight. And she is a known case of chronic duodenal ulcer. And the plain CT sections of abdomen shows mild right pleural effusion with a few well-defined soft tissue density nodules involving bilateral lung fields, predominantly peripherally, and moderate ascites. The calculi noted in the gallbladder.
Ashwati, you didn't finish the plain finding.
Okay.
Plain CT, when there are more findings.
Yes, ma'am.
Look at the subcutaneous tissue, look at the omentum. Go down, go down. Yeah. Yeah. Yeah.
There is a well-defined hypodense lesion noted in the both right and left lobe of livers, and there is diffuse subcutaneous stranding noted in the anterior and posterior abdominal wall.
First, you finish all the findings of liver and hepatobiliary.
Okay.
Then you go to the other areas.
Then intrahepatic biliary radical dilatation noted involving both lobes, left more than right. And there is an ill-defined soft tissue density area noted in the region of porta hepatis, and a calculi noted in the gallbladder, which is contracted. And multiple soft tissue density lesion with omental stranding noted. With a relatively hyperdense lesion in the fundus of uterus. Bone windows show the lateral aspect of the right tenth rib shows adjacent soft tissue reaction and then lytic area within. And lung windows show few well-defined pulmonary nodules in both lobes, predominantly peripheral region.
So now you're suspecting it is some benign process or malignant.
Malignant process.
So any other areas you should look other than the bone and the lungs you have shown? Any other particular organs you should look for?
Adrenal gland.
Yes. What is the status?
Plain study, it appears no lesions noted.
Yes, but you should look for that in plain study also, because once you are tailoring the protocol for the patient, in plain study only if some lesions are there, you can what additional protocol you can do if you suspect any adrenal lesion. Like in this case, we have done only triple phase CT, right?
So delayed in the 15 minutes to look for washer.
Yes. So you can't say that adrenal lesion you should look for only in contrast phase. You should, once you start practicing, you should suspect at least in the plain study and plan accordingly. Okay. Fine. You can go to contrast study. Tell which what phase is that? Is this? Ashwati?
Arterial phase.
Yes.
Arterial phase.
Okay.
The arterial phase show there is an ill-defined soft tissue density region in the region of porta caudate lobe.
Okay.
With intrahepatic biliary radical dilatation involving both lobe. And there is enlarged periportal lymph nodes and iotocaval lymph nodes noted adjacent to it. And the by on tracing common bile duct, intrapancreatic CBD appears normal and the common hepatic duct also can be traced, but the primary confluence and the secondary confluence is not separately visualized from the soft tissue density lesion.
You said the lesion is in the hilar region and the caudate. Can you
Caudate
address
region.
the window and show the exact extent of the lesion? I think you can show in the next phase. On arterial phase it will be difficult.
Yes.
Okay.
Then there are another lesions which appears hypodense, non-enhancing lesion in the subcapsular location of the liver involving both, predominantly involving the left lobe.
Are they just hypodense? Is it the better term? Now we are in contrast phase. Plain study, it is okay. You can say it as hypodense.
Some fluid attenuating lesion.
Yes.
And altered lobar ratio of the liver noted with Capsular retraction noted.
Okay.
And there is a focal non-enhancing area noted in the border of pancreas.
Is there only one lesion in the pancreas? Show me the one which you have shown now. Yeah, it is not the head neck junction. Another region. See, there is. Go down. Down. You're going up. Okay, there is one lesion there, and another lesion after that. Yeah. Okay.
Then
Okay, then.
and the peritoneum appears thickened with a
Okay.
few multiple enhancing
Okay.
soft tissue density nodules.
Okay, so you can go to next phase because arterial phase is not apt for cementic enhancement and peritoneum. Go to portal or venous phase. Let's go to portal phase.
The portal venous phase shows the lesion appears mildly enhanced in the peripheral region with a central non-enhancing area within. And the portal vein at formation shows normal contrast opacification, whereas distal to the lesion, the portal vein radicals are not seen. The lesion, it appears completely encased by the lesion.
The main portal vein, distal aspect itself is not seen. The branches are also very much obliterated. Is there any difference in right and left portal vein?
What's that?
Right and what is the status of right and left portal vein? You want to put it everything in one description, or what is the trace? What is happening to right portal vein? What is happening to left portal vein? Yeah, see, right portal vein is markedly obliterated. Still, you can see some contrast. Left portal vein is completely not visualized, completely involved. Okay. Okay. Now
there is enhancing multiple enhancing soft tissue density nodules in the hepatorenal pouch, in the omentum, with omental stranding and nodularity. The right paracolic gutter.
Okay.
And in the arterial phase, it is shown in the pelvis also.
Okay.
And the stomach wall appears edematous.
Okay. Stomach is not that much distended. Okay, go to the venous phase. Is anything additional?
The venous phase, the intrahepatic IVC.
Okay.
And the junction of middle hepatic vein and left hepatic vein with the IVC appears encased by the lesion.
Okay. IVC is not just encased, there is marked luminal narrowing of IVC. Right?
Yes, sir. Yes.
So, is there anything related to that? Any consequence of a significant IVC narrowing? You can see in the images.
There is tortuous collaterals with this communicating with the paravertebral venous plexus.
Okay, lumbar venous plexus, fine. Then so where should the blood ultimately go? The IVC is occluded, kind of occluded almost. So ultimately it has to reach the heart, right?
Right atrium.
So it has gone into the lumbar venous plexus. From there it should go somewhere. There are some findings. You can abdominal wall, anything other than the fat standing?
Multiple collaterals are also there.
Yes. Okay.
Then the endometrial cavity appears distended and thickened with a possibly a fundal fibroid and multiple enhancing deposits in the pelvis.
Okay.
And a prominent submucosal varices noted in the rectum with the prominent inferior mesenteric vein.
What is the age of the patient?
A 70-year-old.
So this much thickening of endometrium.
We don't expect in this age group.
Yes, and it is quite heterogeneous also, heterogeneously enhancing.
And the further delayed images show the enhancement of the lesion involving porta and caudate lobe appears increased in the compared to the hepatic parenchyma in the delayed phase with a central non-enhancing area.
You can adjust the window and show the extent of the lesion. So in this phase, still there is persistent enhancement. Rather, now the lesion has become more obvious, right?
Nice.
In the delayed phase. Show the transverse colon. Internet connection. See there. Yeah, there.
Multiple deposits.
Yeah.
Over the colon and paracolic rectum.
So any change in the colon, the wall of the colon?
Cirrhosis deposits over the colon.
Yeah, not just over the colon. There is thickening of
There
colonic
is
wall
some
also.
intraluminal extension.
This may be partial this extension, but there is a thickening, wall thickening there. Patient has had melena also. Okay. There is a asymmetric thickening of the focal thickening of the transverse colon also in relation to the large omental deposits, which is kind of directly infiltrating the transverse colon.
So, 70-year-old female presented with complaints of right side upper abdominal pain and loss of weight. These imaging features show an ill-defined soft tissue density area with a delayed enhancement in the porta hepatis involving the caudate lobe and encasing the primary and secondary confluence of bile duct and the portal vein with a moderate gastritis and extensive peritoneal deposits with the lung lesions and a lytic lesion in the possibility of a hilar cholangiocarcinoma with lung mets, significant peritoneal metastasis, and skeletal metastasis, and these multiple cystic lesions in the liver, which appears fluid attenuating and non-enhancing. It may be biliary cystadinoma-like lesion, or in this background, it may be a cystic metastasis also. Then this much thickening of the endometrium in this age group is should be allotted to the clinician for further workup of the lesion.
Okay, so is it just a hilar cholangiocarcinoma? What do you mean by hilar cholangiocarcinoma in general? What are the growth pattern types of cholangiocarcinoma?
The morphological growth patterns of cholangiocarcinoma described are infiltrating periductal type, or polypoidal type, or a mass forming type. Here in this both, sometimes it can be combined, and in this it appears to be a combination of mass forming and periductal.
Okay. What are the types of periductal infiltrating? Any further types, like the staging or the classification?
In
the extent of
hilar
involvement.
cholangiocarcinoma, the staging usually is Bismuth classification, and in type 1 it is limited to common hepatic duct, and type 2 it involves the primary confluence of the hepatic duct, and type 3 it involves either second origin of right hepatic duct or left hepatic duct, and in type 4 it is a combination of both, and type 5 there is a stricture at the junction of CBD and cystic duct, and in this it appears to be type 4.
Okay, type 4. There are two further classifications, right lobe involvement and the left lobe
Type
involvement.
3A is right origin of right hepatic duct, and the type 3B is the origin of left hepatic duct.
Okay, fine. So in this case, is there any arterial phase enhancement of the lesion?
Arterial phase.
Arterial phase. In arterial phase, what else you should look for in this case?
Is there any in this lesion there is no significant enhancement? If it is a primary hepatocellular malignancy, it should show arterial hyperenhancement.
Okay, so there are some enhancing vascular structures are there, which are hepatic artery branches, right? So is there any hepatic artery involvement?
Hepatic artery is prominent, mildly prominent.
On the other side you show the delayed phase and the arterial phase, arterial and delayed phase side by side. When you change the window of delayed phase, where you can see the enhancing lesion better. Yeah, there's there, yes. A little bit lower down where the hepatic artery branches are there. So you can see, keep it side by side and see for any arterial involvement. Okay. So main hepatic artery is okay. Go to the branch. There, down. Yes. So now you compare both. On the right side, is there enhancement? See, the lesion is not limited to caudate lobe and porta. It is involving segment 4A, 4B also. That is why that much capsular retraction is there. Okay. So see, you can see the enhancement reaching all the way up to the capsular surface. So the lesion is extending till there. And now you see the enhancing area In the arterial phase, some of the vessels are traversing through the lesion. There is encasement of the hepatic artery branches. Right hepatic. Right and both right and left hepatic artery branches. Okay. Why is it? Why it is significant?
Because these say these are certain criteria for the resectability of this malignancy, and these are long segment invasion of portal vein or main hepatic artery is considered a criteria for unresectability.
Okay. So other than main portal vein or hepatic artery, branch portal vein and hepatic artery, any contraindication for surgery?
There is a ipsilateral lobe atrophy and contralateral vascular invasion is also a contraindication.
Okay. Ipsilateral lesion and contralateral
Vascular
vascular
invasion.
invasion, or the contralateral, I mean, atrophy and the contralateral vascular invasion. So that is why the importance of hepatic arterial encasement. If not the total encasement, the partial encasement also should be mentioned. The extent of the infiltration or the encasement. Okay. Okay. Fine. So, what is capsular retraction?
It is due to the aggressive nature or the desmoplastic reaction of this cholangiocarcinoma due to fibrous tissue. It will retract the liver capsule.
Okay. Any other conditions causing capsular retraction?
Sometimes the serous variant of the hepatocellular carcinoma can also cause capsular retraction.
Okay. Any other condition which is kind of similar to cholangiocarcinoma?
Sir,
Any other condition where the enhancement is kind of similar to cholangiocarcinoma, where the confusion arises? HCC is not that difficult.
Yes, yes.
Any other
Then,
condition in cirrhotic patient?
Central scar is usually seen in fibrolamellar HCC, which can also show a central non-enhancing area.
Okay.
Should be.
Not central scar. Is there any other kind of scar in cirrhosis?
Central stellate scar is in fibrolamellar carcinoma, and in lesions like focal nodular hyperplasia also scar is seen.
Okay, so okay, fine. There is an entity called a focal confluent fibrosis in cirrhosis. Okay, so certain areas there is confluent fibrosis. Basically, cirrhosis is fibrosis, right? But particular area there may be large area of fibrosis. In that case, also the retraction will be seen, and delayed phase enhancement also may be there. In that case, it will be bit difficult, but you should look for other ancillary features like IHPR dilatation and enhancement pattern. Arterial phase, and any arterial phase enhancement you can expect in cholangiocarcinoma.
There are some unusual variants like mucin hypersecreting variant of cholangiocarcinoma.
That shows arterial enhancement. Where is the fibrotic process happening in cholangiocarcinoma? Which part of the mass?
Along
Which
the
part of
period
the mass? Which part of the mass is cellular? Which part of the mass?
The
is
central
fibrous?
area is fibrous, which show delayed.
Yes. Okay, fine. I'll give you another clue. What is the MRI finding in cholangiocarcinoma?
The dynamic contrast enhancement show the similar images.
No. Enhancement
Even
pattern
T2.
will be leave the enhancement pattern. There's not much of difference. It will be the same. Routine sequences.
T1 it appears hypointense, and T2 the peripheral aspect appears hyperintense, and the central will be hypointense.
Okay, so that means central is scar. Central is the fibrotic process, right? So the peripheral is cellular. So In diffusion weighted image, any finding?
Peripheral, since it is a peripheral area cellular, it may show diffusion, peripheral diffusion restriction.
Yes, peripheral area shows diffusion restriction. Okay. So this peripheral area may show arterial enhancement, arterial phase enhancement. And in the subsequent phase, delayed phase, there will be gradual enhancement of the central part. And the delayed image even for if you take a delayed image after half an hour, 1 hour also, sometimes the enhancement may be persisting. Okay. So any other lesion showing centripetal enhancement?
Hemangioma.
Okay.
Then
The cholangiocarcinoma can show centripetal enhancement, right? Other than that, anything? See, sometimes metastasis can also show centripetal enhancement. See, the peripheral part enhances earlier in arterial phase. Not hyper. What are the type of metastasis, like based on the enhancement pattern? Types of metastasis.
Hypervascular metastasis, which is seen in carcinoma tumors, or hypovascular.
Okay. So in hypovascular, there will be enhancement at the periphery in the initial phase. Okay. In subsequent phase, the enhancement go into the center. But sometimes the central area will be necrotic. There may not be any enhancement at the exact center, but other part may show kind of centripetal enhancement. So how to differentiate these centripetal enhancement from hemangioma?
Hemangioma, the enhancement will parallel the blood pool. The contrast enhancement will be similar to that of the corresponding phase, and there will be peripheral nodal contrast enhancement with the gradual centripetal filling in the delayed phases.
Yes. That is the point. Good. Okay. So, fine. Any other? Can you mention few causes of biliary dilatation?
The biliary dilatation, the most common causes are choledocholitis,
Okay.
or a benign or a malignant strictures, or a recurrent pyogenic cholangitis,
Okay.
or extensive compression of the CBD by the enlarged lymph nodes.
Okay.
Then portal biliopathy.
What is portal biliopathy?
That is the enlarged periportal collaterals compress the common bile duct, result in the intrahepatic biliary radical dilatation.
Okay. So in the setting of portal hypertension or portal cavernoma. Okay. Okay. Other than that, any masses associated with high sphere dilatation other than cholangio?
Other than cholangio, some periambulary mass or a CA head of pancreas.
Okay. Any benign lesions?
Sometimes a passed off calculus can show IHBRD due to papillary stenosis or a benign stricture.
Okay, let me refine my question. A focal intrahepatic biliary dilatation.
Sometimes this early intrapolypoidal cholangiocarcinoma can result in a focal dilatation. Then choledochal cyst.
Okay. Yes. Then something similar.
Intrahepatic stone formation, like the recurrent pyogenic cholangitis.
Okay. What is it called? Intrahepatic stone. Any other terminology?
Biliary lithiasis.
Okay. Biliary lithiasis is like usually with extrahepatic biliary choledochal lithiasis. That is hepatolithiasis. Usually in the setting of recurrent pyogenic cholangitis. Okay. Any benign cystic lesion causing biliary dilatation? See, there is a cystic lesion over there. So
Yes.
you mentioned a few differential diagnoses for that. Or in other words, how to differentiate a simple cyst from a biliary cystadenoma?
Biliary cystadenoma can appear as either unilocular or a multilocular cystic lesion, and sometimes internal septations or calcific foci may be seen.
Okay.
When a simple cyst, the margin will be smooth, and in biliary cystadenoma, it may be irregular. Or sometimes biliary cystadenoma may be associated with the mild periportal hypodensities.
Okay. Mild, it may be associated with mild iris dilatation also. Okay. What are peribiliary cysts? Okay. These are a small, benign cysts, which are usually clustered cysts along the biliary tree. But on imaging, sometimes it will appear like a focal iris dilatation because all the small cysts are clustered together in a row. So that may appear as dilated iris. Okay. Ma'am, Gomati ma'am, any questions?
You can ask about the intervention as
Yeah.
a radiologist.
Yes, yes.
In this
So
patient, since this is unresectable, then for as a palliative measure for the drainage of bile, PTBD and can be done.
Okay.
How will you do? How will you do a PTBD?
First, we have to look for the coagulation parameters of the patient. Look for PKNR and the platelet count, and it should be PKNR should be less than 1.5, and platelet count should be more than 50,000 at least. And the patient is in supine position, and in this patient, due to ascites, that epigastric approach may be better for the access of biliary radicals. Using a 22 gauge needle, after inserting the needle, a guide wire and a catheter is introduced, and both after introducing the needle, it is better a PTBD stenting for this patient.
Yeah. That is, what do you mean? That is internal drainage or external drainage? Or what is internal external drainage? Yeah.
In internal external drainage, this needle is crossed, and both the biliary drainage into external bag and duodenum, that is the normal drainage pathway, is also there in internal external drainage, whereas in external drainage, there is a bile is drained only to the external bag.
Okay. What is the needle you use?
Chiba needle.
Yeah. What is the length of the Chiba needle?
7 centimeters.
No, 7 is for lumbar puncture. No, it's 9.
9 centimeters.
Yeah. Okay. Internal drainage. Do you take the help of the gastroenterologist for the internal external drainage, or the radiology itself will do the drainage?
Radiology.
For the internal drainage, we may take the help of the gastroenterologist because he has to pass the endoscope, isn't it? So we may take the help. If we are doing the external drainage, the radiologist by itself can do it. Okay. So in this patient, will you do a drainage procedure? Is it advisable or non-advisable?
Not advisable.
Why?
Because it involves both the secondary confluence and right and left side.
The patient has got ascites. Patient has got so much of peritoneal and infiltration. What will happen if you put a needle to the biliary tree? It may go for biliary peritonitis sometimes. Sometimes the patient may not go and he may become asymptomatic because the bile has been drained out. But at the risk of the patient, you can attempt. Okay. Okay. So what is your conclusion? This patient?
It's a case of hilar cholangiocarcinoma with extensive peritoneal metastasis, lung metastasis, skeletal metastasis, and a multiple liver lesion, which is fluid attenuating, non-enhancing, and a thickened and distant endometrium, which is suggests further evaluation. And the liver lesions may be biliary cystic adenoma or cystic metastasis.
Very good. You're done well. And we can go to the next case. Anish, any more question to her?
No, ma'am.
Okay.
Ma'am, second case, ma'am.
Yeah, you can start.
Yeah, I'm provided with case of Damodaran, 73-year-old male patient.
You can share the screen.
I'm presenting the case of Damodaran, 73-year-old male patient. He gives history of abdominal discomfort and flexible sigmoidoscopy showed a wall thickening. And he's a non-case of chronic parenchymal liver disease. And since there is highly elevated AFP, suggested triple phase CCT abdomen.
What does the scout show you? Any findings, added findings in the scout to add to your clinical history?
Flanks are full. And
you said Scopy shows sigmoid wall thickness. So what do you should expect?
Bubble loops appears normal only.
Normal. It's not distended, isn't it? It's not dilated. There's no evidence of any intestinal obstruction.
Abdominal, no evidence of obstruction.
Yeah. So how will the large bowel obstruction seen in X-ray? How is the small bowel obstruction seen in a X-ray? This is a scanogram, lying position. But in erect position, what will be the findings?
In supine posture, the large bowel loops will be large bowel lesion. The peripheral dilated bowel loops can be seen with the hostrations. Whereas in small bowel lesions, usually will be towards center, and the valvular conventis will be seen as a more placed more closely, will be more closer, and valvular conventis we can appreciate.
Yeah. Then how will be the valvular conventis? It will go closer and more longer than the hostra, isn't it?
Yeah.
Okay. What will be the maximum diameter to say it is an intestinal obstruction for colon and for small bowel?
For colon, it is 6 centimeter, and for small bowel, it is 3 centimeter.
Will you see air fluid level?
In erect posture, we can see air fluid level.
Large bowel, you won't see air fluid level because it is packed with fecal matter, isn't it? Okay. So, okay, that was, so here you're not seeing any evidence of intestinal obstruction. Okay. So what do you expect? Since they said AFB will be elevated, patient is cirrhotic liver. What will be the contour of the liver in an X-ray? How will you say there is hepatomegaly or no hepatomegaly? See, I'm going exam oriented, okay?
Yeah. The liver shadow, we can, if it is hepatomegaly, the liver shadow can be more, can be seen more towards downward with the hepatic flexure will be displaced more downward. And very sometimes we can also see elevated right dome of diaphragm.
Okay. Okay, but there is no signs of hepatomegaly because you said patient is cirrhotic. So in cirrhosis, what will happen to the liver?
The caudate lobe will be enlarged and left lobe will be enlarged, and the caudate lobe right hepatic lobe ratio will be altered.
So there may be atrophy of the, there can be atrophy of the right lobe, or it can be contracted. So you cannot see a hepatomegaly in a cirrhotic patient. Not necessary, there can be hepatomegaly also, but usually in chronic parenchymal disease, the liver can go for atrophy, isn't it? So you're now seeing hepatomegaly, you're now seeing bowel loop dilatation. So always clinical history is very important, but before you go for a CT. So much of history you got. So what is in your mind before you go to the CT?
Since the patient is giving history of bowel wall thickening, since the patient is already having a cirrhosis and there is elevated AFP, so I would like to consider the possibility of HCC first. But the patient is also giving history of flexible sigmoidoscopy showing wall thickening. I would like to know whether there is any metastatic lesions or any other lesions in the bowel wall.
Also, okay. So what will be next investigation? What will be routinely? What will be a next investigation?
USG will be done.
Yeah. What will you search for in USG now?
USG in liver, I would like to search for first I have to confirm whether the liver is cirrhotic, whether there is portal hypertension, and whether there is any lesions there. And portal vein, I would like to look for thrombus also.
Yeah. So what is the finding in USG? If there is a lesion, if you see a lesion, what will be the surface of the liver?
Surface will be nodular with enlarged caudate lobe, with enlarged left lobe, with the portal hypertension will show enlarged portal vein. And if there is portal vein thrombus, it will be show filling defect with the no color flow.
Yeah. And what is the normal caliber of the portal vein?
12 millimeter.
How much?
12, ma'am.
Oh yeah, 12 to 13 mm, isn't it?
Yeah.
So when the portal vein is enlarged, will you look for the splenic vein and the spleen also?
Yeah, associated with the portal hypertension, there will be splenic enlargement and enlarged splenic vein.
Yeah. Okay. So that is going for portal hypertension. If the spleen is enlarged and there's splenic vein enlargement, portal vein thrombosis also, that can lead to portal hypertension, isn't it? Okay. Okay. Then you can go, because we have no USG is there. We can go directly to CT now. Okay. Can carry on.
Plain axial CT sections showing. And there is evidence of coronary artery calcification.
Very good.
The aneurysmal dilatation of the left ventricle.
Very good.
Liver appears cirrhotic with a nodular surface with the enlarged caudate lobe. Multiple
You can complete.
multiple hypodense, ill-defined hypodense lesions can be seen, and a tiny foci of calcification noted in pancreatic parenchyma. There is evidence of splenomegaly. In kidney, there is a fluid attenuating. There is a hypodense lesion, exophytic hypodense lesion. There is evidence of ascites. There is mild fat stranding noted in the root of the mesentery. There is no evidence of significant dilatation of bowel loops. There is evidence of enlarged prostate with a calcific focus within.
The plain study on the kidney on either side, you could see some area of bilateral calcification, a hyperdense area. What is that?
It could be either the medullary calcification or it could be test dose which is given.
Yeah, it could be either to the test dose or it could be Randall's plaque, isn't it? Okay.
Yeah. Can I go to arterial phase? It's an early arterial phase. The left gastric artery noted showing separate origin, and it is giving an accessory left hepatic branch.
Very good. Very good. Yeah.
And the splenic vein and celiac, the right hepatic branches noted, which appears normal. And a few lesions started showing contrast opacification.
No, 1 second. What about the superior mesenteric? Is it separate origin or from the common trunk? Just see once more.
Left gastric artery, celiac trunk.
Yeah.
A separate branch.
Okay.
Superior mesenteric artery is a separate branch.
Branch. Very good.
It's
Okay.
going down.
Yeah. Okay. Very good observation. Okay.
And there is an eccentric wall enhancing irregular wall thickening noted. And which is in the sigmoid colon, which is appears redundant. With no proximal dilatation of the bowel loops.
Yeah.
And no significant surrounding fat stranding and no significant pericolic lymph nodes. And no significantly enlarged paravitic lymph nodes or mesenteric lymph nodes. And portal vein characterize the lesion. In portal venous phase, there is the lesion showed enhancement. Most of the lesion showing non-rim arterial enhancement, but few showing peripheral enhancement with the necrosis.
Try to look at all the lesion and try to look at the enhancement pattern of the lesions. Okay.
The main lesion, which is in the right lobe, is showing heterogeneous enhancement, and it is not a peripheral rim enhancement. It is heterogeneous. Whole lesion is showing enhancement. Predominantly, even the predominantly peripheral, it's not a non-rim enhancement. It is a non-rim enhancement.
Okay.
And few
this
showing
is portal venous phase. This is portal venous phase, isn't it?
yeah, ma'am. Portal venous phase.
Okay.
It is portal venous phase, ma'am. The IVC also started showing contrast opacification. In portal venous phase, also, ma'am.
If you want, you can go to the arterial phase and put together. Then you can see the lesion separately.
Okay.
Make it dual. Dual or triple also. So that you will get the arterial, portal and delayed phase. Now compare. Look at the pattern of enhancement.
I'm loading, ma'am.
Yeah, it's loading. Don't take your own time. Don't worry. Yeah, that is one lesion. See the pattern of enhancement: arterial, venous, and delayed.
Ma'am, this is an exophatic lesion, which is showing central necrosis, which is non-enhancing, and a predominant peripheral enhancement.
Yeah. Okay. Then come down. Yeah.
This adjacent lesion also showing similar enhancement pattern.
Okay.
But the largest lesion in the right lobe is showing a non-remark enhancement.
Okay. So we have got different lesions with different pattern of enhancement, isn't it?
Yes, ma'am.
You're agreeing for that?
Yeah, ma'am.
Isn't it? Some are showing non-rim enhancement, some are showing nodular enhancement, but some enhancement seen in the portal phase, and even the delayed phase, you're seeing them lesions which has not washed out.
Yeah, ma'am.
So now tell me the lesion which is showing non-rim enhancement and early washout and enhancement with delayed washout.
The largest lesion is non-rim enhancement.
Very good.
There are multiple lesions which are there are a few lesions showing rim enhancement with the necrosis in the center.
Okay.
3 lesions.
If you so now what do you feel now?
If it is a peripheral rim enhancement, it is unlikely an HCC. We have to consider other than HCC, malignant lesions other than HCC could be either metastasis or atypical cholangio.
Okay, very good. Okay, so which is HCC here? Which you feel is metastasis here?
The largest lesion, I feel it is an HCC lesion, but since these other few lesions, it is an atypical lesion. It could be either metastasis.
Yeah, okay. So what is the criteria to say it's an HCC and what is the criteria for saying it's a metastasis? So you should know that, isn't it?
Yeah.
Yeah, what is it?
Arterial phase enhancing, peripheral rim enhancing lesions in the arterial phase is more likely to be a atypical HCC, or it could be an atypical cholangiocarcinoma, or it could be a metastatic lesion. Whereas non-rim enhancing lesions or lesions which are not enhancing with the wall which is showing persistent enhancement in the delayed phases are more likely to be HCC.
Okay. Now you're sitting in as a radiologist, you're sitting in your room and a physician or the surgeon is coming and saying, he want to do FNAC to rule out an HCC. So how will you tell him this is an HCC, this is an metastasis? He wants to do a biopsy or an FNAC. And what is the precaution you will give him or instruction you will give him to the patient, what to do to the patient?
Ma'am, from USG.
USG guide or CT guide, whatever it is. You have to instruct the concerned physician, isn't it?
Yeah. Before doing every biopsy or FNAC, we have to we should consider the coagulation parameters.
Okay.
And we should the INR should be less than 1.5 and platelet should be more than 50,000.
Yeah. Okay. Okay. And I'm just dealing with the liver lesion. Okay. So now, as a radiologist, you want to do some intervention.
Yeah.
What is the intervention? You will think in your mind. And what is the criteria, size
directly
criteria?
I have to take FNAC or biopsy from the lesions, from both the lesions separately I have to take.
Yeah, very good. Yeah. That's what I wanted from you. Then? You have done an FNAC and now from one of the lesion, it has come as HCC. Now you want to do intervention. So what is the size criteria for the intervention? And what is the intervention you will do?
First, we have to categorize the lesion. If it came as an HCC, first we have to categorize the lesion based on BCL2 classification. It is having 0, A, B, C, D categories. And the A category is those single lesions with less than 3 centimeter. And the B are less than 3 lesions with less than 3 centimeter. C lesions are not included in these two, but with no evidence of portal vein invasion and no evidence of lymph node mets or no metastatic lesions. And category C BCL2C lesions are those which are having portal vein invasion or lymph node metastasis or metastatic lesions. And category D are those patients which are having performance score more than 2 or childbirth criteria score more than is C.
Okay. Now, in your CT, how will you report this is HCC or not an HCC? Will you give LIRADs?
Yeah, ma'am, I would like to give LIRADs. If the patient is having more than 18 years and there is evidence of cirrhosis, and if the study is done properly with the triple phase, I could give LIRAD score.
Okay. So for this now, is the portal vein involved or not?
And this portal vein here, we can see filling defect.
Yeah.
On right anterior and the posterior branch of the portal vein is showing filling defect, and the posterior branch is showing an enhancement also. So it is likely a tumor thrombus.
So how will you give the LIRAD?
Since it is involving the portal vein, I would like to give LIRAD's tumor in vein, TIV.
Very good. You have to give us LIRAD, TNV. What is that? Tumor in vein. Is it? Will you advise liver transplantation in this patient?
Surgery as well as intervention is not done in these cases.
Okay. Okay, very good. Because there is a tumor thrombus and LRT IV will never allow for liver transplantation, isn't it? Now come down. Come down. You have told about the lesion. You have few lesion which is showing features of HCC and few lesion which are showing features of METs, or you said it could be
a typical HCC or a Kalanji.
Okay, now come down. Come down. You can make it single if you want. Yeah. Was the lung field given to you?
Part of the lung field.
Yeah. Go up, go up, go up, go up, go up, go up. I think only till here. Okay. Okay. Now come down there. I think the higher cut was not given to you. Okay. There was a lesion in the lung also for this patient. Okay, come down. You said there was thickening of the sigmoid, redundant sigmoid colon.
Yeah.
Now, will you say it is a metastasis or you will say it's a primary lesion?
Since
yeah.
So a submucosal metastasis can be a cause, but
submucosal metastasis is not unlikely for an HCC, isn't it? No? Will you get submucosal metastasis? Unlikely. But here now you can, patient had, what was the history?
Abdominal discomfort.
Abdominal discomfort. But he did not have any history of constipation or melena, nothing was there. But this was an incidental finding. See the pattern of involvement of that colon. See how is it involving? The lesion is going.
Segment.
Yeah.
With the irregular wall thickening, the mural stratification, it is lost.
Yeah. And see the enhancement. See the enhancement also in plane and contrast. See the enhancement pattern. And the length of involvement. Because the patient has, the region has got no luminal narrowing, patient did not have much of symptoms. Even though there is submucosal bulge, you can see that the lesion is bulging into the lumen. There is only very minimal amount of luminal narrowing or stricture. But the enhancement pattern, you can see the enhancement pattern favoring what? You can see. Yeah, go down, down, yeah. No. See the plane? See? Can you see the difference in the enhancement?
It is significantly enhancing lesion.
Yeah. eccentric growth, isn't it?
Yeah.
It's an eccentric, luminal,
narrowing.
yeah, polypodal growth involved, and you can see so much of soft tissue stranding also, isn't it? Adjacent mesentery, we can see the soft tissue stranding, isn't it?
Yeah.
You can put it as now.
A metastatic lesion or
Yeah.
an.
See, we are seeing, yeah, that's how you can explain the liver lesion. And you cannot explain the liver lesion, isn't it?
Yeah.
So now you can give the full report to the patient. How will you give the full report now?
Features of chronic liver disease with multiple lesions, LRTIV, with an eccentric wall thickening in the short segment, enhancing wall thickening like in the sigmoid, with the metastatic lesions in the liver.
Isn't it? That will be. Now, how will you stage it now?
Since
For the bowel lesion, for LIRADS you have staged.
Yeah,
it's a non-resectable, isn't it?
Yeah.
Now, how will you stage now? Yeah.
Since the it is surrounding mesentery showing fat stranding, it is anyway T3 lesion.
Yeah.
And since there is metastatic lesions in the liver, it is M1. And lymph nodes. No significantly enlarged.
Significant enlarged lymph node. Okay.
Okay.
So now, for in this case, now because you have both metastasis and you have HCC, will you? And you said it is LRTIV, isn't it? It's not resectable. What is? I'm not going for this. Anyhow, it is non-resectable. I just want to know. Do you know about what is Millen's criteria? Have you heard?
Child drug means based on creatinine level. Some clinical features. Okay. I don't know.
So what is it? Is for Millen criteria in liver transplantation, no?
Yeah, ma'am. I don't know. Yeah, it is involving creatinine also along with the clinical criteria. Correct? I don't know.
That is 3 criteria is there. If you have a single tumor less than 5 centimeter or 3 tumors, 3 lesion with less than or 3 centimeter. Okay, that is one criteria. Then there should be no extrahepatic involvement. Okay, and there should be no major vessel involvement. That is for resectability. That's why you use for Millen criteria. All the vessels, that is mainly the portal vein, the hepatic artery, extrahepatic involvement, and size criteria. That is Millen's criteria for liver transplantation. Okay, then you should know the segments of the liver. What are the segments of the liver?
We have 8 segments. Upper segments and lower segments. The upper segments, the lower segments are below the level of the portal vein division.
Okay.
First, we can divide it into right and left by a line joining the IVC. The lower segments we can divide into right and left by a line joining the gallbladder at the IVC.
Yeah, very good.
The left again we can divide it into 2 based on the main lobar fissure, which is formed by the ligamentum venosum and ligamentum teres. And the lateralmost one is the segment 3, and medial to the lobar fissure, it is segment 4B. And the right again we can divide it into more posterior one is the segment 6, and the adjacent to which it is the segment 5. And the upper one we can divide it into based on the position. We can divide it by the hepatic arteries. Hepatic veins. The middle hepatic vein divides it into 2, and it is again further divided between by the left hepatic vein and right hepatic vein by segment 2, 5, 2, 4A, 5, and 7.
Okay, very good, very good. Okay, that was very good. So that was because liver transplantation has become more, you should know the segmental anatomy, which is very, very important now, because you have to tell the oncosurgeon or the gastrosurgeon before the when you give the report. So all this should be included in your report. The vascular involvement, the thrombus, the size is very important in your report. And always don't forget to give the LIRACs, whether it is resectable or non-resectable. Okay. Okay. Then this patient, it was actually a non-operable patient because the patient has also lung lesion, which we did not include in this. Okay. Okay, you have done well. Both of you, very happy. I think any more questions you want from the audience? Any chat box question? No. Anish, you want to ask any question? You can ask.
Yes, ma'am. I want to add few more questions.
Yeah, add.
One is regarding the arterial anatomy. You mentioned about the arterial anatomy variation. What is replaced hepatic artery and what is accessory hepatic artery?
Yeah, very good. Yeah.
Sorry, this is an accessory hepatic artery because already from the hepatic artery, main hepatic artery, there is left hepatic artery also. So additional one which is coming from the this left gastric artery, it is a accessory left hepatic artery. Okay. If it is there is no hepatic artery from the hepatic branch, it is replaced left hepatic artery.
Okay, good. One more thing regarding LIRADs, you mentioned that in cirrhotic patients younger than 18 years, it is not used.
Yes.
What is the rationale?
Less than 18 years with congenital patients going cirrhosis, we are not using LIRADs. And if it is...
what about adult patient without cirrhosis?
If there is hepatitis B infection, we can use cirrhosis. If already there is treated cause of HCC, we can use LIRADs.
Very good, very good. Yeah.
Fine. What is the rationale for that? That is my question. Okay, fine. LIRADs is basically a quantification of the risk of possibility of HCC, right? So in a patient who is at risk of HCC, so this LIRADs is used. So an adult patient with hepatitis B infection or adult patient with cirrhosis are at risk of developing HCC. That's why this LIRADs comes. What are all the imaging characteristics or the criteria used to categorize the, grade the lesion in LIRADs grading?
First, arterial phase enhancement.
Okay.
Then size of the lesion.
Okay.
Then capsular retention, persisting capsular enhancement and persisting capsular enhancement.
Okay.
Then threshold.
Okay.
Then threshold growth.
Threshold growth. Okay. What is threshold growth?
6 months, 50% increase in size.
Okay. Size, diameter. Okay.
Yeah.
Okay. So, what among these are the absolute criteria to definitely diagnose a lesion as HCC? Can you diagnose a lesion as definite HCC on CT?
Capsular retention, enhancement, arterial phase and heterogeneous arterial phase enhancement with the capsular retention is there.
Okay, arterial phase, non-peripheral arterial phase enhancement is the absolute criteria. Okay, with other associated finding, one or more than two based on the size is there. Then you can categorize it as LIRADs 5. So LIRADs 5 means it is, what is LIRADs 5?
It is highly suggestive of HCC.
It is almost diagnostic of HCC. You don't need biopsy. You can start the treatment or intervention or like ablation or whatever. Okay. So the problem comes with LIRADs 4. LIRADs 3. What is the protocol for LIRADs 3? To find the LIRADs 3 lesion. You mentioned that threshold growth. So
yes, sir.
What is threshold growth? Growth of what duration?
6 months duration. if it is more than 50%.
Okay, fine. So
Growth,
that 6
we
months
can-
means Leyard's 3 lesions. You can ask for follow-up. Okay.
Yeah.
You can look for, start applying Leyard's in subsequent images. Imaging. Okay. So in grade 4, in grade 3, you can do follow-up. In grade 4, the problem comes. You have to do biopsy. Okay. That is the importance of Leyard's. That is the importance of radiologists in HCC. Ma'am, voice.
Okay. One last question. What is LRM? I forgot to ask that.
Malignant lesion other than HCC, which could be either metastatic lesions, atypical HCC, or cholangiocarcinoma.
Okay. What will be the pattern?
Peripheral enhancing lesions.
Okay. It will have remanency or it can have a targeted appearance, isn't it? Peripheral washout also will be seen in delayed phase. Okay. Very good. Okay.
I have one more question for you. Since it is dealing with metastasis, one last question.
Yeah.
One last question. How will you differentiate a hypovascular metastasis from an abscess? Liver abscess.
Wall characters.
Okay.
Parenchymal wall characters that the abscess will be thick walled with 3 walls, 2 walls. It will have the inner granulation layer and then outer the edematous liver, compressed liver parenchyma, which will the granulation, the inner wall will enhance earlier and the outer will enhance later. Whereas metastasis, it will be a single wall with irregular inner wall.
Okay, and gradual centripetal enhancement. Okay. Any what is the name of the sign for these two? Any name signs? You mentioned that layer. Yeah, target sign in metastasis. And what for abscess? What is the
Double wall sign.
Double target sign.
Double target.
One is single target sign, one is double target sign. Okay. Right. Okay, good. Well done. Okay,
Yeah.
ma'am,
Yeah.
I think we can.
Both of you did very well. I thank Dr. Devi Krishna and Dr. Ashwati for doing such beautiful case discussion. I'm very happy. Thank you so much. Okay, and Anish.
Yeah, I think it's time for us to wind up this session.
Wind up, yeah.
I would like to thank our IRIA State President Gomita ma'am, IRIA State Secretary Rijo sir, State Academic Coordinator Ramesh Anay sir, and Venu sir, and our team, IT team, which is MedPiper, MedPiper team for the support, and the 2 young PGs, energetic PGs who have presented very well, and all the radiologists and the residents who are watching this program. Thank you all once again. The next program will be on this Saturday, again based on hepatobiliary case discussion, not PG presentation. PGs will be there, but it will be multiple cases presented by the speaker. The speaker is Dr. Krishna Kiran, sir. Is a professor of radiology in Father Muller Medical College, Mangalore. So I invite you all for the next session. Thank you.
Thank you. Thank you, Soumya.
Thank you.
For the platform.
Thank you so much.
Okay.